allow them walking without brace. For few weeks, they should walk with a long leg brace on. That I feel. And yeah, they can take out in between. They can do exercise, but while they are walking, put that long leg brace on while walking. That's all, not in the back. Because these patients have poor muscle function, they tend to fall, lot of release may be required. Even in the patient, those who are very obese, you have done fantastic knee, upper part is very heavy, sometimes they do not have control over the core group muscles are weak. If you say them walk with the brace for 2 weeks, that is safer, always better. And once you think your patient is fine, he is doing well, take out the brace. Only walk, during walking, not throughout the time. That is safer method, especially Indian patients. Muscles are weak, bones are weak.
Yeah. Anything to add, Dr. Hist? Anything to add? This is the last one. Yeah, sure.
I realize it's a very useful trick is that do not cut too much of TPR. You are more proximal. If you make a small TPR cut, you have a much stronger cortical bone than that. And then most of the cases, as CS is rightly saying, you can avoid the extension steps. That is the one trick.
And another important thing, when you cut the bone with the, do not trigger fully or otherwise that saw blade may shatter your bones. So just trigger mildly, minimal vibration over the saw blade. That is, even pressure lavas can take out all the. Do not use pressure lavas with full force. These 2-3 things are in rheumatoid. It is very important, and do excellent severity.
And cut the margins first. Because the saw blade is moving inside.
I used a terrified paradigm with immunosuppressant. We start immunosuppressant 3 weeks after the session. Thank you.
Robotic bones. In a patient with short stature, osteoporosis, I have often find that when I have put the trial implant, the medial epicondyle tends to slightly open up a bit. So in those cases, if we are doing a PS knee or a CR knee without the constrained implants, please be sure that you have those screws and the washers ready with you, because in those patients it is quite possible. And I have seen 3 or 4 patients in which I have required in these very small osteoporotic bones that medial epicondyle slightly opening up.
Yes. So, sir, please, I don't need your opinion. You agree to it.
He doesn't need your opinion.
No. So, as this was in fact Dr. Yadav's case. So this was a 56-year-old lady with severe OA bilateral knee who underwent simultaneous bilateral TKR in 2003. So pre-op deformity was 15-degree varus and 10-degree flexion deformity. So posterior stabilized extend prosthesis with insert of size 12 was used. Knee was stable with this insert in full flexion, extension and mid flexion. So 10 years later, means in 2013, patient developed sudden onset of the pain and swelling in the left knee following slipping out of stairs. Patient had difficulty in standing up from the sitting position, difficulty in walking upstairs with locking episodes, and there was some clicking present. Range of motion was 10 to 110 degree. So she presented with this kind of X-ray. So any cases? Prof? This case one is
Right side?
no, left side. Sorry? It's not. Yeah.
There can be gap fracture. That can lead to such symptoms. You have to confirm it with ultrasound. You have to confirm it with very stable. So that's one pointer that something happening to the poly only. And if it's stable poly, there's no instability, then probably it's a CAN. And they have not his case. There are many cases in the history which are except I also mentioned that, which I found when I opened it up. So it's not 10 years. I'm watching
So I think
knees
we have
since
got
96. Yeah, but I've seen only 3.
Very rare. I think absolutely right.
Actually, the balanced knee, because he said balanced knee.
Yeah, absolutely. So I think one thing is a patient will get the posterior drawer test first if you do it carefully. So this case, the ESR CRP was normal, bone scan was normal. So it is absolutely right. We got this fracture of the cap, post effect. Tibial post was fractured. That's it. So the main mechanism is the fracture was due to anterior root wear leading to weakened post, and eventually fracture occurred during the high flexion by the posterior lift of force. So this is the mechanism of fracture of the post. Yes, sir. So we have done just opened it and replaced the insert with some bigger size of the insert, and the knee was stable in flexion extension. So this was the post-op X-ray. Just to balance the knee. So next case, I think. So we have just published this literature. So next case. So this is a case of a 60-year-old male with 2-year-old posterior distal femur fracture, fixed like this, and she came with a severe knee pain. Sir, my mentor Yadav sir. Yes, sir. Now she came with severe knee pain. She needs to be replaced, or we should do something for the knees.
We will do basically. Here we will do external femoral alignment. We may need image intensifier. Either you need cast, because distal femoral cut is only problem. Rest other is not an issue. So for otherwise rest everything is simple.
Is there any of the person with the opinion that we should remove the plate and do the knee?
Fracture is healed. Yeah.
So for you only.
When he was, it is healed. It is healed. So it can be done.
So this is the lateral view.
Yeah. It is healed, I think.
So we did CT also.
Yeah.
To see whether the fracture is healed or not.
Yeah.
So this was APL lateral. So this was the CT. So it's still not infected.
So it is not serving any purpose. So how long it is fixation?
2 years.
It should be removed.
Should be moved.
Yeah. And this is fracture of condyle, huh?
Yes, sir.
It should be removed.
Should be removed.
Yeah. Then fix it
With the plate.
definitely, or use that now that Dr. Anant was using, extension rod.
Okay.
Or sleeve as Dr. Phil showed for the stability. That
might work.
uncemented sleeve rod and
So any more options?
It depends. I mean, you're seeing a non-union part of the fracture.
Still not united.
Is it
Still not
non-union
united.
all the way up the fracture? Because it's a vertical fracture. The whole thing's united. So you do need some stability on this bone before you start. But you may not need to have screws close to the joint, because once you fix it,
That's the main issue. We don't need the screws. The screws.
so what I would do, in fact, I wouldn't take the plate out. I'd take the distal screws
Yeah,
out.
absolutely right.
I'd do the knee replacement, then I'd put some more screws back in.
That's what we did. Absolutely right. So I normally prefer navigation by ISS system, the Zimmer one. So I did navigation in this case. But in ISS system, we need to introduce about 3 centimeter of the rod inside. So we need to take the distal screws. So we take out the distal screws, did the distal femur cut. But the main issue was this plate was still protruding at the distal surface. Now what we do? When we used to sit the implant, the plate was impinging over the prosthesis.
Do you have a Midas Rex? Because if you've got a Midas Rex, you can cut the end of the plate off.
Yeah, absolutely. That's why we use Midas Rex, cut the plate, and use this. So this was the final.
What about the non-Indian? What about the...
So we have just put the plate inside. Don't disturb the plate.
If you got a non-union for the last, if you got a non-union for the last year, it's going to remain a non-union for the next 20 years. So what you can do is actually to get the most of that tomorrow. I would have been happy if you had exchanged the plate for a plate which is on the medial side.
Yeah, medial side.
Rather than
Absolutely.
a plate on the
We could have done that.
You could put some compression screws across from the medial side and bone graft it at the same time.
And you could have used this.
Grafting has been done, sir. Grafting has been done. But the SE is absolutely right. And actually the plate was not applied correctly. It should be a medial plate actually. Yeah, it should be a medial plate.
Excuse me.
Yes, sir, please.
What was the cause of pain in this case? The cause was non-union. What you have done for the non-union?
Arthritis is also there, not only non-Indian.
It was an arthritic knee at the end of the day, remember that. Just one thing about external jigs. I mean, don't be frightened of them, external jigging. Intermedullary jigs did not appear until about 1983-84, when David Hungerford designed the anatomic knee system. Before that, we always used external jigs. And all it's doing is creating your femoral alignment. And if you do it carefully, you can still use the external jig on the system.
Normally, we use extramedullary jigs. Sorry, sir. 2 years. 2 years follow-up. Post-joint replacement. Follow-up. I have only 6-month follow-up, sir. Yes, sir, definitely.
Show this case in the next conference.
Okay, sir. Definitely, sir.
With the extra fixation.
Now I think I have a very strong feeling that this knee is
Weight bearing,
in valgus of the 15.
Future.
We'll play weight, sir.
This will fail in
Just,
liver component.
You see the screw.
I mean, it's just a suggestion. I don't know whether. I think you need something to fix this implant to the shaft, because the condyles are fractured right across.
So we already have left the plate.
No,
That is not working. That's why it went into non.
they are.
In fact, sir. 3.
You need that implant. That non-union portion will be osteoporotic after a while, and then this is my presumption that it might then collapse, and it might lead to an implant failure. So, as we were discussing, there could be a medial plate along with the intramedullary, something to hold that implant onto the
You want
shaft.
a long rod with a medial plate inside.
I mean, this was a plausible thing which came
Your
up.
rod will actually have to go proximal to the proximal most screw by about 5 to 7 centimeters. Otherwise you have a stress riser.
If you don't have a rod inside, there is a possibility of it. I'm not.
If you see the fracture line in the second screw, we can still see the oblique fracture line. Here the second. So what is it?
Yeah, next time I'll just show that follow.
Dr. Nisikant, even if other
pessimistic.
even if other screws were in place, when you were making various cuts in the femur, did you see any movement between the fragments?
No, not at all.
So, do you want to say that though on CT scan it seemed to be non-union, still the other parts of the bone they had taken up?
Yes. But I think the middle plate concept was good. We should have done in this case. One more case, I think. So this was a case of 5-year-old post of bilateral knee. So I will concentrate over the left side. So I want to revise this knees. So AP and lateral views with this uncontained defect over the tibia. So how to fill this uncontained defect over the posterior medial or tibial side? Yeah, absolutely. Sleeve, cones, or
That depends on the pocket of the patient. You got to sleeve or cone.
so normally our patients don't have much money, sir. Mine. So we have used some Indian techniques. So we have done the impaction bone grafting. We all are doing in hips. So we have done it in knees. So this V-shaped mesh has been used. Fix the screws. Then the impaction of the bone grafts, and then this. So we have at least a 1 year follow-up, sir. At least 1 year follow-up. 1, 2. Yes. So 2 years follow-up.
Yeah.
So 3 weeks in place. 3 weeks in place.
Yeah.
That with
Full weight bearing with walker. Full weight bearing.
So one more.
But when you are putting brace, on the bed you are allowing exercises?
Every exercise is allowed. He has to put brace where he is walking. That's all.
Sorry to interrupt. An important announcement is
Good, Nishika.
एक कार UP 78 CC 4005